Dr. Abhimanath sir, Dr. Ramya ma'am, Dr. Nandini ma'am to be the chairperson for the next session. I welcome Dr. B. Sriram sir, consultant medical gastroenterologist, VLML Hospital, who will share his expertise on emergencies liver disease management.
So, good evening everyone. So, at the outset, I like to thank the organizing team, Mohan Raj sir and Pawan, for giving me an opportunity for organizing this beautiful conference. So, I will be giving a talk on the emergencies in liver disorders, particularly focusing on the management part. So, coming to the emergencies, we can classify these into two broad types. One, the emergency in chronic liver disorders, and next in acute liver disorders. In chronic liver disorders, I will be covering on variceal bleed, hepatic encephalopathy, SBP and HRS-AKI. In case of acute liver disorders, I will be giving inputs on the ALF, that is acute liver failure, and few points about AFLP and HELP syndrome. So coming to the emergencies in chronic liver disorders, the first emergency we face is the variceal bleed. Why it is significant? It is a life-threatening complication of cirrhosis and it requires prompt treatment to reduce the mortality. And whenever a cirrhotic patient presents with a upper GI bleed, we have to assume it is a variceal bleed until proven otherwise. Why? Because the 30-day mortality is around 15% and it is usually associated with other complications like SBP, acute kidney injury and aspiration pneumonitis. So coming to the management part, the first step is the recognition and risk stratification. So always suspect whenever a CLD patient presents with a hematemesis mellitus or shock, you have to assume it's a upper GI bleed. Use scoring tools like CTP or MELD sodium for early risk assessment. The next step is resuscitation. So always have an airway protection if the patient has a massive bleed or if the patient has altered consciousness level. Then you have to secure the IV access to large IUB cannulas should be done, and you have to immediately start them on crystalloids. Then we have to follow a restrictive blood transfusion strategy. That is, you have to maintain the hemoglobin in the range of 7 to 8. Why? Because over transfusion can in turn increase the portal pressure and then impose the patient at the risk of rebleed. And for prophylaxis of SBP, we always start them on antibiotic like ceftriaxone. So coming to the next management is these patients will be started on vasoactive agents. So there are two vasoactive agents we commonly use. One is octreotide, which is given at the dose of 50 microgram stat dose followed by infusion dose of 25 to 50 microgram per hour. And the next drug is the terlipressin, which is given at the dose of 2 mg IV stat followed by 1 mg every 6th hourly, and the duration of treatment varies from 2 to 5 days. So this is a flow chart explaining where whenever the patient presents with a upper GI bleed, it should be followed by initial assessment and followed by resuscitation with securing of airway, breathing and circulation. Then we have to start the patient on vasoactive agents followed by antibiotic. And then we have to subject the patient for a diagnostic endoscopy probably within 12 hours. Then we have to confirm whether it is a variceal bleed, and the variceal bleed can be from a esophageal varix or a fundal varix, or it can be even from a duodenal varix in rare cases. And we have to modify our therapy according to the site of bleed. Whenever it is a esophageal variceal bleed, we have to proceed with the banding. If it is due to fundal varix or a duodenal varix, we should be followed by glue therapy. Then after that, we can maintain these patients with the vasoactive agents and with antibiotic prophylaxis. And most of the cases, the bleeding can be controlled in 85% of the cases. However, in 15% of the cases, there can be a rebleed, and these patients must be put on the transplant list, or we can salvage with the tips. So this is a picture showing there is an active spotting from a bleeding esophageal varix where the emergency banding has been done and there is control of the bleed. So this is a picture showing a patient with a large fundal varix with active oozing of blood, and for that we have then the glue injection with immediate cessation of the bleeding. So if we find a large fundal varix where even after glue injection if there is no resolution of the fundal varix, then we can go ahead with the US guided coiling of the fundal varix, where we can directly inject 1 or 2 coils followed by glue injection into the varix, which can cause resolution of the varix. So what do we do for a refractory variceal bleed? So whenever there is a refractory bleed, even after a procedure, then we can try a re-therapy after 24 hours. It can be in the form of again do a banding or a glue. If it again fails, then we have to step up our therapy. It can be in the form of putting a SEMS, or it can be other radiological procedures like BRTO or TIPS. So this is the stents where we put a fully covered esophageal metal stent. In a case of a refractory esophageal variceal bleed, these stent poses the mechanical pressure and then stoppage of a beat for a temporary period where the patient can be again proceed with a TIPS procedure. So what is TIPS? TIPS and BRTO are both are the intervention radiological procedures. In TIPS, where through the IVC we puncture the hepatic vein, then through the liver parenchyma we go into the portal vein. When we create a tract and we put a stent there, thereby decompressing the portal pressure, thereby reducing the complications, particularly the refractory bleed. This BRTO, that is balloon occluded retrograde transvenous obliteration, is a procedure specifically done for a refractory fundal variceal bleed, where through the femoral vein we gain access to the IVC, then from there to the left renal vein, and from there we go to the gastrorenal shunt, where we identify the outflow tract of the gastric varix, then we occlude the outflow tract, and then we specifically inject a sclerosant agent into the fundal varix, thereby causing resolution of the varix. So coming to the next emergency, which is hepatic encephalopathy, we know it's a spectrum of neuropsychiatric abnormality in an individual with a liver failure after excluding other brain disorders, particularly patient presenting with a portostemic shunting, mainly due to accumulation of neurotoxins, particularly ammonia. We know that the etiology is 50% of cirrhotic versions during the disease course, and it can be a first complication in 10 to 15% of the patient. Why it is very important? Because it can be often the primary or associated cause for the hospital admission, or in the first episode the patient has a risk of developing 45% recurrence, and it has a very poor prognostic outcome. These patients are at risk of 35% survival at 1 year after first HE episode. So there is a classification for hepatic encephalopathy. It can be classified into 3 types. It can be A, B or C. A is due to acute liver failure, B is due to portostemic bypass, and C is commonly we see that is due to chronic liver disease. In the third type, the C type, it can be again classified into episodic, persistent or minimal. So coming to the precipitating factors, we know the common precipitating factors are GI infections, that is SBP. It can be due to GI bleeding or diuretic overdose or electrolyte disorders. In case of recurrent HE, it can be due to an underlying electrolyte disorder or an infection. So coming to the grading of West-Haven criteria, so the commonly the hepatic encephalopathy is usually broadly divided into covert and overt hepatic encephalopathy. In covert, we have minimal HE and grade 1 hepatic encephalopathy, where the patient will have only abnormalities in the psychometric analysis. In grade 1, we have a trivial lack of consciousness level or altered personality disorders. In grade 2, where the patient have a overt HE, the patient will have profound personality changes with disorientation for time, and when the grade increases, that is in grade 3, patient will have a bizarre behavior followed by a confused state, or the patient will be in semi-super state, or in the grade 4 patient will be comatose, where these patient has to be managed in a hospitalized setting. Coming to the management part, so initially again for the management of hepatic encephalopathy, we have to admit the patient, we have to stabilize the patient, secure the airway, breathing and circulation, then do a GCS scoring system, then do a complete neurological examination, and then we have to proceed with the diagnostic workup. Always do a CT or MRI brain to rule out any intracranial bleed or infarct, because which can mimic a hepatic encephalopathy in few cases. Then do a diagnostic workup. Then you have to rule out other causes like electrolyte imbalance, underlying liver function test, and you also do the ammonium levels. Then you have to screen for other infections. You have to send the cultures for the ascites, blood and urine. Then you can come to a diagnosis of whether it is HE alone or HE associated with any precipitating factors. Then you can then you can start them on the anti-HE treatment along with treatment of the precipitating and contributing factors. Whenever you have a questionable HE, that is when it is present with a focal neurological deficit or other signs of meningitis, always involve a neurologist, get a neurologist opinion, and then you can go for higher investigation in the form of CT or MRI brain or EEG or even lumbar puncture, and then management can be planned accordingly. So this is a stepwise approach for the management of HE. First step is confirm the diagnosis, consider it's a overt hepatic encephalopathy, then you can start them on a anti-HE measures, that is giving them an lactose. It can be oral or enema if the patient is in altered sensorium. Then you have to add other drugs like rifaximin. Then you have to assess the response after 12 to 24 hours. If the patient is in hepatic encephalopathy, the patient will have a rapid response. If that's so, you can continue the regimen, then adjust the lactose according to the bowel movements of the patient 2 to 3 times per day, and then optimize on the nutrition level. So if there is no improvement, then you have to go for the next step, that is reevaluate the diagnosis, reevaluate the precipitating factors. You have to check up the medications, you have to stop the diuretics, beta blockers and other NSAIDs if any, correct the electrolyte abnormalities and go for correction of the infections if any. Then you can also do a re-imaging. You have to rule out the underlying portal vein thrombosis or HCC, or even you can identify large shunts. Then you have to escalate the therapy. So for escalation of the therapy, we can try for a BCCA or L-arterin L-asparagate therapy, or even can also give zinc. Sometimes if they found a large shunt, we can also go for shunt embolization. And the final step is prevent the recurrence. So you have to put on them on pharmacological management, advise them for lifestyle changes, and finally put them on the transplant list. So these are the common medications we use for hepatic encephalopathy. Lactose practically traps the ammonia in the colon, it have laxative effect. And you know the dosage is 20 to 30 ml 2 to 3 times and titrate according to the 2 to 3 stools per day, and it's for long-term maintenance. Then rifaximin, which reduces the ammonium producing gut bacteria, the dosage is 550 mg BD, again it's used for long-term. Then others are like escalate therapy, where we give the L-orthonin L-aspargate, which enhances the ammonium detoxification. Dosage is 5 to 10 grams IV per day, and its duration is variable whether it is given as for acute setting or it's an adjuvant therapy. And zinc supplementation can also be tried, which acts as a cofactor in ammonium metabolism. The dosage is 50 mg per day. So coming to the next emergency is SBP, that is spontaneous bacterial peritonitis, which is defined as a bacterial infection of the ascitic fluid without any intra-abdominal surgically treatable source of infection. So in an OP basis, the incidence is around 1 to 3%. In a hospitalization, it is around 10%. So what are the risk factors for a patient who develops an SBP? The common risk factors are whenever the ascitic fluid protein is less than 1 gram per deciliter, patient with a prior episode of SBP, patient has a varicose bleed, patient is a sarcopenic, or patient is on long-term use of PPA, or patient with advanced cirrhosis, that is CTP more than 9 points, or patient has a bilirubin of more than 3, or urea creatinine more than 25 or 1.2, with serum sodium less than 130. So based on the ascitic fluid analysis, we can again classify the SBP into 4 types. That is the classical SBP, where the neutrophil count will be more than 250 with culture positivity. Culture negative neutrocytic ascites is the count is more than 250 with culture negative. And third type is monomicrobial non-neutrocytic bactericidis, that is the neutrophil count will be less than 250, culture will be positive, where the patient can be symptomatic or asymptomatic. And the fourth type is the polymicrobial bactericidis, where there will be multiple organisms in the culture which suggest the secondary peritonitis. So what is the next step? After confirming the diagnosis, we have to start them on empirical antibiotics immediately, and the choice of antibiotic depends upon the setting, whether it is community acquired or nosocomial SBP. When it is community acquired, we have to start them on third generation cephalosporins, and the drug of choice is cefotaxime, 2 grams IV 8 hourly, or it can be ceftriaxone 2 gram IV OD. In case of nosocomial SBP, or if you are suspecting a multi-drug resistant strain, it can be piptas or carbapenem based upon the local resistance, and we can also modify according to the institutional antibiotic program. So coming to the step 2, after starting antibiotic, these patients must be put on albumin for renal protection, as they are in increased risk of developing AKI. So these patients must be put on 1.5 gram per kg on day 1 and 1 gram per kg on day 3. And the step 3 is secondary prophylaxis. The indication for secondary prophylaxis are patient with prior SBP or lower ascitic fluid protein. And the drug of choice is either you can use norfloxacin for 400 mg BD, or it can be ciprofloxacin 500 mg per day. And the duration is again it's used for a long term until transplant or resolution of ascites. So these are the classical drugs used for prophylaxis. As I already mentioned, for a secondary SBP prophylaxis, either the preferred therapy is norfloxacin, and the alternative agents can be cipro or levofloxacin. Cipro is 500 mg and levofloxacin is 250 mg, and the duration is indefinite as long as the ascites is present or the patient goes for transplant. Again, primary prophylaxis, when the patient with advanced cirrhosis, the same drugs are used. And the third is for acute GA bleed. In this case, the ceftriaxone is used 1 gram daily for 7 days, or when the patient is stabilized, we can put them on oral antibiotics like norfloxacin or ciprofloxacin. The only change is norfloxacin here, it should be given as a BD dosage for 7 days. Coming to the next emergency, that is acute kidney injury, which is defined as the increase in the serum creatinine of more than 0.3 milligram per deciliter within 48 hours, or 50% rise in the serum creatinine from the baseline within 7 days, or the reduction in the urine output less than 0.5 ml per kg per hour for 6 hours. So we know that kidneys are the most frequent extrahepatic organ that is affected in a patient with CLD, and the incidence is around 20 to 30%. And the cause for the AKI is multifactorial, the pre-renal AKI being the most common, followed by ATN and glomerulonephritis, and HRS comes after that. So I'll be discussing about HRS AKI, where the diagnostic criteria remains the same, that is the cirrhotic patient with a clinical significant ascites. As I already mentioned the definition of AKI, then no improvement in serum creatinine after 2 days of diuretic withdrawal or expansion with albumin, no evidence of any septic or hypovolemic shock, no use of nephrotoxic drugs, and no structural damage of the kidney as evidenced by urine analysis or with normal renal imaging. Coming to the newer classification, previously HRS-AK has been classified into type 1, type 2. Now the newer classification came where the definition is either you have to do in HRS-AK or it can be HRS non-AKI. In non-AKI there are two types, HRS-AKD or CKD. As we already seen the definition of HRS-AKI, now we can go for HRS-AKD or CKD definition. That is GFR less than 60 ml per minute for less than 3 months with structural damage less than 3 months is used for AKD. When it is more than 3 months, then we can call them as CKD. Coming to the management part, whenever we found a diagnosis of AK in cirrhosis, always look for warning signs like acid-base imbalance is present, whether there is any severe electrolyte impairment, or the patient is in volume overload state, or in patient is in uremic encephalopathy. If these signs are present, then immediately you consult and get an opinion from a nephrologist, and we can start them on renal replacement therapy. If these warning signs are not present, then you have to stop the offending drugs like diuretics, beta blockers or NSAIDs, and then you have to empirically start them on antibiotics. Then if the patient is volume depleted, then you go for an if the patient present with the GI bleed, you go for restrictive transfusion strategy, and if the patient present with vomiting, diarrhea or diuresis, then you can start them on crystalloids 2 km bolus, and you can wait till the urine output is more than 0.5 ml per kg per hour, and also along with albumin infusion, that is 20% human albumin given at a dose of 1 gram per kg. If the patient has a 10 ascites, then you can also try therapeutic paracentesis under albumin coverage. Then review the patient after 6 to 12 hours, and if the patient is improving, then monitor the renal function and urine output closely. If the patient is persisting or have a progressive AKI, then screen for other phenotypes of AKI like intrinsic or post-renal, and if it is not present, and if the volume is replete, then HRS-AK is suspected, then you can start them on vasoactive agents like terlipressin along with albumin in the dosage of 20 to 40 gram per day, and if there is no response to this, again you have to go for a RRT therapy. So coming to the vasoconstrictor used in HRS-AKI, so we have these 3 drugs, that is terlipressin, which is can be used in a continuous infusion dose or as a IV bolus. The continuous infusion dose is started as a 2 mg per day, then you can slowly increase the dose every 6 hours, every 2 mg 6 hours, based upon the fall in the creatinine value more than 25%. And the most important side effect for using terlipressin is the ischemic events, and patient is in volume overload. And for norepinephrine, we have to use this a continuous infusion dose. The dosage is 0.5 to 3 mg per hour, and you can increase 0.5 mg every 4 hours, keeping in mind that we have to maintain the mean arterial pressure more than 10 mmHg and the urine output more than 0.5 ml per kg per hour. Then along with this, we can also try using midodrine with octreotide with a dose of 7.5 to 15 mg every 8 hourly, and octreotide it can be given as a subcutaneous dose 100 micrograms. And what is the criteria for discontinuation of the drugs? Whenever the serum creatinine falls within 0.3 mg per deciliter of the baseline, or if there is no improvement after 48 hours, or when the patient develops serious adverse effects to these drugs, then we have to start them on renal replacement therapy and then listed them for transplantation. And if the patient shows a partial response, then we can continue these drugs for 14 days. Coming to the emergencies in acute setting, that is ALF. We know that ALF is a clinical syndrome which is characterized by encephalopathy, jaundice and prolonged PTNR in a patient without any pre-existing liver disorder within 4 weeks of the onset of the symptoms. In India, the most common cause for ALF is hepatitis virus, and among the drugs it is ATT. In a pregnant patient, the most common cause is hepatitis E virus. Although in 50 to 47% of the adults, still the etiological workup can be negative, and the most important point again is in children, in 13 to 20%, again the etiological workup can be negative in case of ALF. So coming to the classification of ALF, it can be classified into hyperacute stage where the patient develops hepatic encephalopathy within 7 days of the jaundice. If they develop jaundice between 8 to 21 days, we can call them as acute liver failure. If they develop HE within 21 days to 26 weeks of jaundice, it is called as subacute, and it is more than 26 weeks, we call it as chronic liver failure. Coming to actually already mentioned the etiology, the common etiology is viral. It can be hepatotrophic virus like A, B, C and E, or it can be due to non-hepatotrophic virus like herpes zoster, varicella and dengue. The next most important cause is toxins. The toxins, particularly rodenticide poisoning, that is the yellow phosphorus, which is very important cause of ALF in our part of practice, where then next comes the drugs. The most common drugs is ATT, which is then followed by anticonvulsant drugs. Coming to the next part is the vascular etiology. It can be Budd-Chiari syndrome or hypoxic hepatitis. In pregnancy, there are two common causes, HELP syndrome and fatty liver of pregnancy, and the rare causes can be due to Wilsonian crisis and autoimmune hepatitis. Coming to pregnancy related ALF, there are two hepatic emergencies, that is HELP syndrome and acute fatty liver of pregnancy. The maternal mortality is around 20%. Prompt delivery of the baby in these emergency note offers a good outcome and thereby eliminating the need for emergency transplant. However, in certain cases where there is a persistent elevation of lactate levels in presence of severe HE, then this identifies a patient at greater risk of severe disease and they should be referred for transplantation. So coming to the workup, whenever we see a patient with ALF, we have to confirm the diagnosis and rule out the other differential diagnosis. So do an complete LFT with PTNR, image the liver, and if needed, we can do a transjugular liver biopsy, and you can also order other tests to rule out tropical syndromes like dengue, scrub, and leptospira. For determining the specific etiology, always screen for the virus infections, that is HBsAg, anti-HBc IgM, then anti-HAV IgM and anti-HEV IgM. In selected cases, we can go for HSV and varicella zoster IgM, and we can also go for EBV and CMV PCR also. Then to rule out Buchiari syndrome, do a Doppler study. Then to rule out that is ischemic hepatitis, do an ECG and echo. Then autoimmune markers in necessary cases, and toxicology seen, particularly paracetamol in required cases. And for determining the complication and prognosis, we have to do the blood workup like CBC, procalcitonin. We have to send the cultures, and you have to do a chest X-ray, renal parameters, and most important thing is you have to monitor the arterial ammonia, do an ABG for lactate level monitoring, and the most important is you do a thromboelastography for component transfusion. Next is I will be focusing on certain organ management in case of ALF. So particularly coming to the CNS complications, for optimizing the cerebral blood flow, we have to do elevate the head end of the patient by 20 to 20 degree, correct the fluid balance, don't overload the fluid, maintain the mean arterial pressure at around 60 to 70 mm Hg, and hyperventilate to keep the PCO2 at 35 to 40. To prevent surges in the intracranial pressure, always intubate the patient when the patient has in grade 3 or grade 4 encephalopathy, and you have to monitor for seizures. So you have to do an EEG to look at it, and you have to maintain the sodium level between 145 to 150. To reduce the cerebral edema, we have to use mannitol in this setting, and the dosage is again 0.5 to 1 gram per kg. So if you are using a 10% mannitol, it can be 350 ml, or the 20% it can be 175 ml, and it should be given over a period of 20 minutes. Next is managing AK in ALF. So we know the conventional indication for renal replacement therapy in a patient in ALF with AK, that is uremic complication. It can be pericarditis or uremic bleeding, it can be fluid overload, it can be severe acidosis, it can be persistent hyperkalemia, hypermagnesemia, or oligonuria. So in this case, we have to do a continuous RRT preferred over intermittent HD, as it is better tolerated with lower chance of increased intracranial pressure. And early institution of CRRT for persistent hyperammonemia, hyponatremia may reduce the mortality. And in these cases, we can do a half dose unfractioned heparin, or even we can try a heparin free CRRT in these cases. And always remember, we can always combine the liver support therapies, that is we can combine plasmapheresis, that is PLEX, along with CRRT in a patient with AK in ALF. Coming to the management of lung injury, that is acute lung injury or ARDS in ALF, always sedate the patient with propofol and keep the patient on low tidal volume and minimal PEEP levels, and you have to maintain the PCO2 between 35 to 40 mm Hg. And for weaning of the patient, percutaneous tracheostomy can be done safely even in presence of severe coagulopathy. So these are the certain do's and don'ts which I have already covered. So coming to correction of coagulopathy, all these patients should not be transfused with component transfusion in case of any elevated PTNR or other coagulation abnormalities, which is very common in ALF. So only the correction is needed whenever the patient has an active bleeding or we are planning for any invasive procedures. So how to correct? Then we have to do a thromboelastography. Then we have to choose which component we have to transfuse. It can be a FFP, cryoprecipitate, or platelet, depending on the deficiency. Coming to the infection part, we know we have to follow the institutional antibiotic program, that is protocol, whichever we followed in their own institute. Then you can start them on that, and again you can give a prophylactic antifungal in selected cases. Then coming to the management like drugs, other drugs, we can start them on N-acetylcysteine. The dosage is 150 mg per kg on the first hour, which is then followed by 50 mg in the next 4 hours and 100 mg per kg in the next 16 hours. and it should be given in a 5% dextrose. Sorry. Coming to the nutrition part, always put this patient on NG tube and start them on enteral feeding to decrease the enterobacterial translocation. And the sugar should be monitored and the blood levels should be maintained between 90 to 110 mg. If there is fall in blood sugar, always give 25% dextrose. If the patient goes for hypoglycemia, give 50% dextrose as soon as possible. And the most important point is early referral for tertiary care center for transplant. If the patient is worsening, always refer the patient early for transplant. What is the role of plasmapheresis? So whenever the transplant setting is not feasible, then we can try plasmapheresis, which has a very effective role, particularly in ALF due to toxins, particularly the allophosphorus toxin, rodenticide toxin, where standard volume plasma exchange which done of around 3 to 4 sessions has shown excellent improvement in these patients, and they can even eliminate the need for going the emergency liver transplant in these patients. However, in few patients, ALF patients, it can also act as a bridge for transplantation. We can put them on plasmapheresis 3 to 5 cycles, and if the transplant is getting delayed. Coming to liver transplant, we know that whatever the case of ALF, the patient has a worsening liver failure, then we have to use a dynamic scores. That is, we have to calculate the scores daily. The most common used scores are the Alfred score and the MEL sodium score, where we have to daily monitor the scores, and if we have a scores which is keep on increasing on day 1 and day 3, then we have to refer the patient for transplantation. Both DDLT and LDLT transplant has given a good outcome. DDLT is usually done in settings with good disease donor rates where ALF receives allocation priority, whereas LDLT is better suited for experienced centers with limited access to disease donor organs. So managing any emergencies and liver disorders is also a teamwork. We have to involve the physicians, we have to involve the surgeons, we have to involve the interventional radiologists, intensivists, and the transplant surgeon. Thank you.
That's a nice talk, Dr. Sriram. It is comprehensive, and also in the limited time, you have covered all the emergencies in liver disease. Particularly, one thing extra I could think is like acute portal vein thrombosis, causing a sudden worsening of cirrhosis and pain abdomen, postprandial pain abdomen. Any questions from the dais?
That was a very extensive and a very nice talk. You've covered most of the complications. I just had few questions for you. So you had spoken about TIPS and BRTO. So I wanted to know what is your experience. In your experience, which do you think is better, TIPS or BRTO?
I think if the patient has a refractory fundal varicose bleed, I think we can go for a TIPS now. There are certain prerequisites for BRTO. There are certain prerequisites for BRTO. That is, the patient should have a gastrorenal shunt. So if the patient has a proper gastrorenal shunt, and if they only have a fundal varix which is bleeding and which is not responding to a conventional treatment, that is endoscopic procedures, then we can go for a BRTO. Even if after failing of BRTO, if the patient is again bleeding, then we can go for TIPS. TIPS is like a salvage procedure before transplantation.
I had one more question. You were speaking about toxins.
Yeah.
So I just wanted to ask your experience. Do you use NSTL system because for allophosphorus?
Yeah. No, always any kind of ALF patient, we tend to start them on NSTL system, because this drug, even though it has acts as adjunctive drug, it somehow helps in the regeneration of this glutathione. So I think all the ALF patients should be started on NSTL system, and depending on the response, we have to step up the therapy, because it is not the drug of choice. It is a part of management, and if your patient is worsening, then we have to go ahead with other management. Like we have to go for plasma exchange. If the patient is not responding, then we have to list them for a transplant, and we have to proceed with the transplantation.
It was a wonderful talk, sir. Role of plasmapheresis in non-toxin mediated ALF.
Yeah. In non-toxic mediated, even it has a role, ma'am. That is depending on the degree of ALF again. So if it is due to viral related or other causes, in case of acute Wilson crisis or in autoimmune hepatitis thing, we can try plasmapheresis, because depending on the response, if the patient is responding well with even 2 to 3 cycles of plasmapheresis, we can delay the transplant in this patient. So we can try for other causes also, provided the only contraindication for plasmapheresis when the patient is an advanced ALF, having severe hepatic encephalopathy, or patient has severe sepsis, or the patient is in persistent hypotension, then that we can use the plasmapheresis. So in that cases, we can deny the transplant.
Also, I'd like to ask you for highlight about ammonia levels for diagnosis, especially in the setting of acute liver failure. especially for the transport and the pay, they tend to take venous
Correct,
blood,
correct,
which causes
correct.
false positive thing.
And
So
there's
I'd like
huge caveats in the serum ammonium level measurement, depending on how we take, at what time we are sending the patient, whether it is venous or arterial. The only thing is the serum ammonium level does not correlate with the severity of the disease, whether it is hepatic encephalopathy or ALS, anything, it does not correlate. Only it has a high negative predictive value. If the values are normal, then we have to think whether it is really a hepatic encephalopathy or not. So I think it can act as adjunct in the management, like we can do the blood test and to rule out other cause of hepatic encephalopathy, other cause of encephalopathy, we can give.
thank you, sir.
And do you think there is any role for primary tips?
Primary tips, I think it depends on the institute which we follow, sir. I don't think straight away we have to go for primary tips. I think again we can try the therapies which we are failing with that, we can go for a primary tip.
Actually, there is a interesting journal in Journal of Hepatology. They published primary tips. Actually, they do they will measure the HVPG, and if the HVPG is more than 20, means there is a high chance even if you do endoscopic management, that patient tend to rebleed. So they first measure the portal pressure. The portal pressure is high, then they directly put the stent tips. Other patients, we can go for endoscopic management. For that, for every patient, you have to measure the HVPG.
Thank you, Sriram. Thank you.
Thank you for this captivating session, sir.